Apologies, not everyone can.
No, that's enough. I'll see that later. Go around your father. I'll go show you, Brian.
Good morning, everyone. Good morning, everyone, and welcome to another Wednesday talk. Today we'll be briefly discussing about optimizing surgical outcomes in the nasal sinus surgery. This is to remind ourselves of the important details that can improve surgical outcomes, minimize complication, and also improve patients' outcomes. There's nothing to declare. The early invasion of endoscopic sinus surgery, it is considered that it is a minimally invasive procedure, and it uses a gold standard for treatment of most nose and pharyngeal sinus pathologies. And it is considered safe in the matter that it preserves anatomical land. It eradicates the disease. Because
I think it's me.
so the procedure function of improve. Among other applications.
Is this lady going to get a scan, do you think? Barney's.
Applications apart from the main endoscopic sinus surgery transnasal approaches includes transphenoidal and transorbital approaches for the anterior skull-base lesions. The post-operative care is equally important to achieve best outcomes, and we see our patients make sure that we remove the crusting or retained cloths and also packing material for those who use absorbable packing material. In the initial steps of managing sinus diseases, of which mainly are inflammatory, the clinical efficacy of the use of intranasal corticosteroids in all different forms of sinus disease, with and without nasal polyps, has extensively been studied. And it is recommended as a medical management for most of the conditions, which offers favorably a safe profile for use. On the other hand, oral corticosteroids, there's a controversy in utilization of them. One has to weigh the risk and benefits of using systemic corticosteroids. One of the important significance of using systemic corticosteroids is the shrinkage of nasal polyps in patients with chronic sinusitis with nasal polyposis. But also one should also remind themselves that there are a number of side effects that are involved with the use of systemic corticosteroids. There is steroid-induced diabetes mellitus. To achieve a maximum surgical safety and access and success, one has to make sure that intraoperatively you maximize your visualization so that at the end of your procedure you have reduced operating time, you have minimal blood loss, and with a good vision you will have less complications associated with your surgery. Among the modalities of assessing the preoperatively for surgery include the radiologic evaluation. William and the colleagues in the United States came up with this mnemonic of simplified algorithm of assessing the CT scan prior to sinus surgery, which has helped a lot in identifying and familiarizing with the anatomical variation in each patient, also reduce the potential risk. Addresses the Cribriform plate, the Lamina, papyracea, Ostiomeatal complex, including the ethmoid, and also the sphenoid and the anterior ethmoid artery. So, starting from the Cribriform plate, this can be well visualized in the coronal plane of the CT scan, and it is the separation of the nasal cavity from the skull base, and the vertical distance from the fovea ethmoidalis to the nasal cavity, in continuity with the lamina fibrosa, which forms the olfactory cleft or olfactory. This is commonly injured during endoscopic sinus surgery. It can be confused with the superior attachment of the middle tabulates in case it is lower. The Keros classification addresses the depth of the olfactory group, and we have type 1, which is olfactory group that is less than 3 millimeter deep. Type 2 is a 3 to 7 millimeter. Type 3 is more than 7 millimeter. Type 3 is associated mostly with complication, iatrogenic techniques in surgery, as well as we can see that there is a close proximity to the anterior ethmoid artery, the skull base. When we look at the coronal scans of the Cribriform plate, one must familiarize themselves, or one must make sure that they look for symmetry. For example, in this case, we have this should be Keros 1 and Keros 3 on the contralateral side. So each side has to be addressed in a manner that is safer for the patient. Looking at the lamina papyracea, this can be visualized better in the axial and also the coronal scan. We know that the lamina papyracea is a thin layer of ethmoid bone that forms the medial wall of it. And when this region is dehiscent, it can lead injuries, mostly fat herniation, also injury to the medial rectus mark. And also you can have injury that during ancillectomy and also during ethmoidectomy. In this example, we see the dehiscent lamina papyracea with almost protruding contents into the nasal cavity. There are also variations that can predispose the lamina papyracea to injury. One of them is the ancillate process attachment. In the scenario where you have hypoplastic maxillary sinus, it is also referred to as the silent sinus syndrome. You have the ancillate process close. This is one of the reasons to cause injury to the patient. And also variants of ethmoid hair cells, pneumatization within the lamina papyracea into the maxillary sinus, the hala cells, and also lead to injury associated with surgery. The Olodis cells, these are the posterior air cells which are pneumatized within the sinuses, and the main risk that they cause is proximity to the optic nerve and also the internal carotid artery. The different septation that is formed by the Onodi cells are usually directly attached to the optic nerve, the carotid, with the community. Moving these Onodi cells, one can cause injury to the optic nerve and the internal carotid artery. The Ostiomeatal complex. The main reason for most of the sinus disease is the obstructed complex. And the endoscopic sinus surgery mainly address obstruction in this region and to ventilation because of disease associated. If you look on the left of the right of the screen, you see the Ostiomeatal complex formed by hiatus similaris, the ancillary process in mandibular, also the maxillary sinus. Different variation that can occur at the Ostiomeatal complex include the concabulosa, which is the pneumatization of the middle tabulate. We have paradoxical middle tabulates, which are the middle tabulates which have a concavity in the middle side rather than the usual lateral concavity of the middle tabulate towards the side. So they can also obstruct the Ostiomeatal complex. One should familiarize themselves with pneumatization in the sphenic sinus, as this is in close proximity to the middle prana fossa, anterior prana fossa. The commonest type of pneumatization is considered as the sella. The other variants are the pre-sella, the conca type. So in the sella type of pneumatization in the sphenic sinus, at some point, more variation can appear and pneumatization of the clinoid process can be evident. This predisposes the optic nerve to injuries, as its chances of dehiscence within the optic canals. And the last part of addressing the radiological assessment is the anterior ethmoid artery. This is the branch of the ophthalmic artery that supplies most of the portion of the coronary sinuses, notably the frontal ethmoid and the sphenoid sinuses. Injury to the anterior ethmoid artery can cause retroorbital hematoma. This is a risk factor for blindness during surgery. The anterior ethmoidal notch is the landmark that we utilize to denote the location of the anterior ethmoid artery in the coronal scan of the coronal CT scan. And the higher the anterior ethmoid notch is apart in the fovea ethmoidalis, it's considered more safer than when the anterior ethmoid notch is hanging into the nasal cavity. So it is important that surgeon looks at different angles of views, because this is very important in seeing the actual pathology in the the individual patients. So angles are everything, very important. So during surgery, we have mentioned that we need to maximize visualization that can help us progress quickly with the surgery, reducing operation time, minimizing complications such as blood loss, and also the ones that we've seen, optic nerve, orbit, and anterior spinal fossa injuries. Intraoperative control, patient positioning, very important. We put the patient in our practice, we put the patient in a 15-degree angle in neck inflection. We can also do reverse Trendelenburg, 15 to 30 degrees as well. And the head is usually rotated slightly towards the surgeon to maximize economics, as well as the monitor and navigation is placed in such that the surgeon and the assistant are more comfortable. So there are a number of factors that can hinder your visualization. So preoperatively, nasal endoscopy is very important to familiarize yourself and plan ahead of what you're going to do during endoscopic sinus surgery. Enlarged tabinate, deviated septum, or other disease that you can see here, variation. This is a concave villosum. It's massive and it's mostly anterior. It almost looks like a tabinate itself, even bigger than the tabinate. And prior to surgery, to achieve significant exposure, visualization or lateralization of the inferior tabinate can give you an extra space, a few millimeters that you can utilize to put your instrument and endoscope feet, make it possible for you to complete your surgery in an effective manner. In case of presence of disease, it is important that you need to orient yourself in the anatomical landmarks. For example, here we have the polypoid tabinate, and the polyps are shaved off from the tabinate, and you can clearly see at the end that you can now identify the tabinate in contrast to other pathological or anatomical relation. This big concha, which was infected. And in this case, this is a tumor which is infiltrating the nasal cavity rising from the sinus. So the bulking of the tumor will help you see your landmarks very well and proceed with your surgery safely. Intraoperatively, bleeding can be controlled initially by infiltration, the use of cautery. We prefer bipolar cauterization, and in case of excessive bleeding that is not responding to mucosal cauterization within the nasal cavity, then we do SPA cauterization. It's not a complete ligation of the stenopalatine artery, and this significantly reduces the amount of bleeding that you can have during your surgery, and it will improve your visualization, identifying landmarks for results. Post-operatively packing, we rarely use post-operative packing once we are sure that we have controlled hemostasis, but absorbable or non-absorbable materials can be utilized to further reduce post-operative bleeding. And the most important part is the step-by-step approach. We all know that surgery is a systematic approach from one landmark to the other. And the sinus surgery, we have the gate system, which is commonly known. Antenatal process, Lamina, superior tabulate, the face of sphenoid as your initial landmarks flowing ahead. The important structures that you need to protect the middle tabulate, in cases of severe disease where the middle tabulate has to be removed, and also in case of access that the middle tabulate has to be but as much as possible, the middle tabulate is preserved. It's a common landmark. Navigation system can also be of additional importance for primary or revision surgery. It's important in the frontal and sphenoid approaches. Last part to optimize post-operative period, post-operative care, cellular irrigation, continuation, post-operative debridement to facilitate mucosal healing and improvement of general patient. These are my references, and thank you for listening. I welcome you to join the discussion and also sharing your different experiences.
Thank you very much. Any comments from the audience? Any questions? Thank you very much for that. I appreciate it.
Thank you for attending.